Welcome to the Stat AI podcast.
Welcome to the future of emergency medicine, a realm where artificial intelligence isn't just a buzzword, but a beacon of hope and a tool for transformation. I'm DJ Apakama. My co-host Ethan Abbott and I are both emergency physicians, and we have witnessed firsthand the burgeoning role of AI in our field. Our everyday experience grappling with healthcare disparities and social challenges have led us to a pivotal question. In the wave of AI applications, what changes are coming to emergency medicine, and will they be for the better? This podcast was born not just to ask these critical questions, but to seek out answers from the experts, to understand and to demystify the potential of AI in emergency medicine. We believe in bringing this conversation to the wider community to embrace AI as a tool for positive change. This podcast is our exploration of that future, a journey we invite you to join. So let's embark on this path together to learn, to question, and to envision a new era of emergency medicine enhanced by the power of AI.
Ethan, did you see that paper in Nature Medicine, Evaluation and Mitigation of the Limitations of Large Language Models in Clinical Decision-Making? Really rolls off the tongue.
Yes, I did. Thanks. That was a paper by Paul Hager et al., and it looks like it was published July 4th, actually, which was just a few days ago. Thanks so much for sending that, and love to briefly talk about it. Obviously, won't get into a deep dive because we don't have as much time. Tell me your thoughts on it and where you think we're going with large language models for clinical decision-making.
Yeah, well, before I do that, how about we catch all of our listeners up to speed, just in case they were not spending their 4th of July reading academic papers. But so the patients that it was looking at were patients presenting to the emergency department with one of 4 common abdominal pathologies, so appendicitis, cholecystitis, diverticulitis, or pancreatitis. And the study used data from Mimic to include 2,400 real cases. The intervention was the use of large language models in clinical decision-making. So the study evaluated several state-of-art large language models, including Llama 2, Clinical Camel, and Metatron in their ability to diagnose and recommend treatments for the specified abdominal pathologies. The comparison of the diagnostic accuracy and clinical decision-making capabilities of LLM versus human physicians. So the meat of this was, are the LLMs as good as the stocks? The study then compared the LLM's performance to that of clinicians in a realistic clinical situation framework where LLMs must gather information and make diagnostic decisions autonomously. The primary outcomes that were measured included diagnostic accuracy of LLMs compared to human physicians, adherence to diagnostic and treatment guidelines by the LLMs, ability of LLMs to interpret laboratory results correctly, overall readiness of LLMs for autonomous clinical decision-making. Overall, the study found that current LLMs perform significantly worse than physicians in diagnosing abdominal pathologies, often failing to adhere to clinical guidelines and misinterpreting the labs. These models are not yet suitable for autonomous clinical decision-making due to high error rates and the need for extensive clinical supervision. So I think without getting into the numbers too much, that was the main points of the article. But now we can dive deep into those if you want a little bit. What were your takeaways, Ethan? What did you think?
Yeah, I think it was a very interesting approach. I like the fact that it was really trying to push the large language model to move beyond into clinical decision-making and synthesis of more complex data to make decisions. The Mimic data seems to kind of be everywhere these days. I'm not sure if the whole world is now using this to test large language models. It would have been interesting to see it within maybe some EHR data, but still, I mean, it's a great data set, and I think it serves its purpose. When you drill down to what they found across at least these 3 models, and they have a specific figure 2, and as well as figure 3, you can see the diagnostic accuracy for some of these conditions was quite poor. So for example, for appendicitis, if you look at the 3 models that they use, again, the diagnostic accuracy was pretty good for appendicitis. It was 74% for one model, 82 and 78.4. But then when you get into some of these other abdominal pathologies, it drops off significantly. So cholecystitis dropped as low as 33.8%. Diverticulitis, 34.2 is the lowest, and 39.2. I think there's certainly some concerns about whether or not moving beyond some of these maybe more complex diagnoses. I'm not sure if their cholecystitis and diverticulitis is a more sort of complex diagnosis to make, but certainly there's some real questions raised about using these models for clinical decision making. And I'm really glad that they were able to sort of push this forward and to really test these models to see if they were able to accurately make the diagnosis.
I think that's, interesting to me was that the choice kind of abdominal pathologies, because I think as an emergency physician, so much of whether or not I'm suspicious about a patient's abdominal complaint is in their exam, right? And, I know that they were giving in kind of the plain text examination, but, this kind of touches at what it means to be a physician. And there's a gestalt here that I don't know if it's really truly captured in essentially the setup of kind of piecewise acting, giving the LLM kind of the information. We did a very similar study earlier in the year, kind of with the word autonomous practitioners in there. But I think the difference between that study and this one is that, with that study, we're really trying to constrain the model a little bit. And so we were seeing what constraints were necessary in order to get the model to a place where it could start to do these tasks correctly, right? And I think the only model that showed any real use case was a RAG with GPT. And so I think you're going to be, we're using some of these smaller LLMs, not these frontier level ones, Llama 2, right? Not Llama 3. I don't think that these models were ever, basically suggested as being something that was ready to go clinically right this second. And so for me, I would love to see kind of this study done again with other constraints to kind of get the LLMs in the place where they are taking in the data reliably and using it. Because I think it actually can be done, even though it wasn't shown in the study.
Yeah, and there's a lot to unpack in this study. I think also one of the things that was interesting is that the models were not able to follow diagnostic guidelines, but also failed with treatment as well. Across all the conditions, it really didn't achieve a performance that was acceptable. I think the one big take home that I got from this article was the authors state, we show that models perform worse when all diagnostic exams were provided, typically attaining their best performance when only a single exam was provided in addition to the history of present illness.
It's definitely an amazing study. And this is the kind of work with LLMs that we need, right? In order to make that turn around the corner where we're actually seeing these things implemented in emergency departments. This is exactly the right type of study. I think, again, my not critique, but I would say it's a limitation of the study, right? That we didn't use kind of the most powerful models available to us. And I know just anecdotally, when I am trying to do, kind of a similar testing of a clinical scenario, and I feed information to kind of a smaller, more nimbler model, sometimes I get into trouble with the context window of my prompt where I'm trying to put in the prompt plus, the added information that of course has been de-identified, and give it to this model. And, I'll reach a context window limit. Right. And so, I wonder if, some of the failures or why kind of, what you were just saying, where it works better if you give it only one test instead of all the tests is because you're running into issues with kind of the context windows in some of these models. So again, just interesting to think about. I think our next guest, is a great person to talk to about exactly some of these issues between implementation and, practicability and also limitations of these models. So, without further ado, we'll be talking to Dr. Nick Jeans today. So today we're here with literally I'm not being hyperbolic here, my favorite ED informaticist ever. And that is because Dr. Nick Jeans was my mentor once upon a time and actually got me got me interested in the field of clinical informatics. And he is currently the director of informatics at NYU Langone and is also the clinical informatics director, the clinical informatics fellowship director.
That's right.
So without further ado, we are happy to have you here, Nick. Go ahead and say hello to the people.
Oh, thank you for that nice introduction, DJ. And I wish I could take credit for some of your amazing accomplishments, but the truth is you were always very motivated and talented, and just a pleasure to work with you. And happy to see you too again, Eve.
Great to see you too, Nick. It's been a while. So I think we were going to just start off, if you can just sort of tell us a little bit about your background and how you got involved in this field and maybe some of your training, and just kind of start from ground zero, and then we'll kind of go from there.
Sure. Well, I was in the right place at the right time. And I was starting emergency medicine more than almost 20 years ago now. And it was an amazing time where electronic health records were just sort of being standardized and being adopted in large numbers. The emergency department at the time had a best of breed system. It was built for speed and efficiency. And then a few years later, meaningful use was being enacted, and people were starting to talk about that and the importance of enterprise-wide electronic health record implementation became like clear and apparent, and using these systems to kind of follow patients from ambulatory to the ED to inpatient, the benefits became apparent. And so there was a lot of optimization to be done, a lot of customization for the emergency department environment, and that coincided exactly with finishing residency. And so I started a fellowship at that time. And it was not an ACGME approved fellowship at the time. There was no informatics proper ACGME fellowship. So it was sort of like learn by doing and watch some online modules and maybe meet some people at conferences. Yeah, it was a great experience. And just a few years after that is when the fellowships really got formally kicked off, and when board certification became a possibility in 2014. So that's when I did that. I stayed at Mount Sinai for a number of years, and as new technologies kind of came up, we started to look into telemedicine, virtual or urgent cares, and then remote patient monitoring. So all kinds of new things were coming up, and it was fun to be in emergency medicine and kind of start to adopt this new technology.
That brings me kind of to a point that I want to make sure that we clarify early. So clinical informatics, artificial intelligence, these can sound like maybe buzzwords to your average emergency physician. Maybe delineate them. Tell us what you think kind of your brain in clinical informatics, and then give us a quick definition for the non-experts in the room.
Sure. It's easy to say like clinical informatics, it's the radical notion that clinicians are better off with a computer than without. And it doesn't seem very controversial, but sometimes the computer can actually make things a little bit worse. So it does need some optimization and some forethought and some planning. And I think emergency medicine is particularly well suited for informatics because we are often operating in the dark. We don't know these patients. We've never met them before. Sometimes they can't tell us about their history, what's going on. So bringing more information to the point of care, whether it's health information exchange, whether it's clinical decision support or guidance, guidelines, I think well within the realm of informatics. And that's kind of when I read about AI, when we talk about generative AI and its potential in electronic health records, and I kind of bring that lens of clinical decision support, which I was just reading, we got new fellows that just started in July, and I was looking at one of the textbooks for informatics, and there was a chapter written by some Mount Sinai informaticists, and the chapter on CDS, clinical decision support, is like, it's more than just alerts. It's true. Like it's alerts are a big part of it, and pop-ups and red banners and so forth, but also sometimes it's just the design, the interface, the nudges that are present, design cues, order panels, documentation templates. There's all like a million ways you can subtly and overtly kind of guide clinicians to do the right thing, the safer thing, the approved thing. So AI, I feel, is just another kind of tool in that armamentarium, and maybe it's the most powerful tool. Like it's going to be transformative in a lot of ways, but I do kind of view it through that lens of CDS.
One of the things we want to talk about is just kind of dive into your QI initiatives and research portfolio that you have now, and kind of what you've been working on the last few months, and
Sure,
kind of
sure.
update us.
Yeah, we're doing some cool things across NYU, Langone Health, but also in our emergency department. I think we've got some fun, interesting, helpful projects. We just published this manuscript in JAMIA about using GPT, using our HIPAA-compliant, secure local version of GPT to read radiology reports and isolate and explain incidental findings so that patients can more clearly see that in their after-visit summary.
Incidentalomas,
Incidentalomas, yeah.
Love that.
Yeah, and it's something we could probably do a better job on, like in the moment when you're talking to a patient about their CAT scan results, their X-ray findings. They're in the emergency department for a specific reason. There was some symptom that brought them there, and so you order this imaging study. You're looking for this answer, and then you can talk with the patient about it. And it's kind of not at the front of our minds to kind of say like, oh, by the way, there's this nodule. It's probably nothing, but get that looked at in 6 months. Put it in your calendar to follow up with your doctor. And it's like, it just doesn't, not at the top of mind. So what if GPT could be kind of autonomously reading these radiology reports and skimming for this text, identifying it, and then bringing it to our attention in the ED? Look, with 21st Century Cures Act, the patient already has access to these radiology findings, but it's hard for them to kind of read and parse and kind of understand the significance of what's being discussed. So summarizing that in a patient-friendly way, presenting it to the ED doctor for, editing if necessary, and inclusion in the AVS. We never want to cut the ED doctor out of the loop. But I think this was a great idea. This is Carmen Wu, one of our safety chiefs, quality and safety chiefs, really kind of conceived of it and started working with our predictive analytics team that handles a lot of our generative AI and our Department of Radiology, which has been for years kind of looking at natural language processing to kind of better summarize text so that clinicians and patients can make more sense of what the radiologists say. So it turns out GPT does a very good job at identifying these incidental findings. Although I can recall sometimes where we asked GPT to summarize it at like a patient-friendly level, and I think we, was it 8th grade education or something like that, so there's not a lot of ambiguity. We can even ask it to look at the patient's preferred language and translate it if we have to. But there was one occasion where we remember there was like a normality seen in the thymus, and it went off on like describing the thymus to the patient. It's like, it's this butterfly-shaped gland in your neck. Like, you can feel it if you really try. Like, it was like, all right.
I feel like the major thing with every LLM is they really love talking. Like they're not. You have to always instruct them to be brief.
That's usually my first personalization is to let's get to the point. But this is almost ready for production at our environment. We're adapting it now for the latest version of GPT. But we were satisfied with its accuracy and its summaries, and I look forward to continuing this work.
I think there's a lot of models that, in general, the AI space, where we're all kind of stuck at the model development and model validation stage, and really that next push to kind of clinical implementation is what's missing. So it's really nice to hear that you guys are kind of moving towards that, and we'll actually get some real patient data.
Yeah, I give a lot of credit to our leadership that recognize the potential of GPT or generative AI in general, and kind of quickly move to get a HIPAA compliant version available for us to experiment with patient data, to like upload a lot of documents and to see how good GPT really was at summarizing and being accurate. Another project that I would also like to kind of take into production at some point is about handoffs. And I don't know how your experience has been, but there's often cases like, of course, handoffs are crucial. Of course, they're a source of error if they're not done well. And handing off to inpatient from the emergency department is like, it's a great opportunity to get on the same page and review the case and make sure no one's missing anything. But sometimes, especially when I am coming into like an afternoon shift or something, and I hear about a patient and then quickly have to hand that patient off to the inpatient service, like it can be a lot of detail and a lot of things that need some summarization. And so that I sound good on the phone when I'm talking to my colleagues, I want to sometimes get this kind of chart biopsy. So that was my motivation to say, can GPT do a good job of these cases live? And then I really wanted to get this in front of clinicians and get their survey results, their impressions. And sometimes it's tricky to build these pipelines, these automated flows, and it can be expensive too, with a lot of data being reviewed by GPT and summarized and then sent out. So I said, I can do this myself. We had a little QI team that was kind of saying like, all right, we're looking at the track board. We've taken some time off of our afternoon and we see all these patients waiting for handoff. just go into the chart, extract the results and the notes and the vital signs and so forth, give it to GPT, get a brief handoff summary, and then just message the providers that are working in the ED and saying like, hey, is this accurate? Is this safe? Is this useful? Or would you use this right now if you had to give a handoff? And it was really eye-opening. It was really great to kind of get that kind of real-time feedback. And look, of course, it's ED clinicians. Sometimes people are busy. They're like, I can't. I'm in the middle of something right now, and it's like, of course, it's fine. This is just for our edification, and like if we get good feedback, we'll push forward. So it was really great, and we actually got some really insightful comments, and we got some seasoned faculty that are like, wow, I didn't know the technology had come so far so fast. And also we got some feedback, like people were convinced that they were seeing a hallucination, or they were seeing something that like didn't make any sense. And I was like, all right, that's probably good. That's a good hallucination. All right, thank you. That's good feedback. And then I would go back and look at the chart later and be like, no, the triage nurse actually recorded.
Right.
Or there was always like we had yet to find like we can set the temperature, the creativity of these models. We can set them down to 0. So we want just the facts.
Just the facts.
Yeah. And so I was kind of surprised that people were reporting hallucinations, but then it's like if you pore over the chart and look at all these details, you'll actually see that we have yet to find a hallucination.
What do you think in terms of the clinicians who, I guess both sides, who found it, useful or not useful? What about this specifically did they find it? Was it the aggregation of the data? What made it helpful or not helpful, I guess, specifically, do you think?
Yeah. I had these ideas that it was going to be the really complicated cases, or the patients that were like not a slam dunk admission, like maybe failure to thrive, or just not looking the same as they used to look. And maybe it's a little bit of dehydration, and maybe there's a UTI, and maybe there's a few other things going on that they just didn't feel safe to go home. But like it's kind of hard to sometimes review all that stuff with the hospitalist and go through the patient's past medical history and their baseline. I thought maybe those summaries were going to be more helpful and rated higher by the ED clinicians, but the ratings were high across the board. We did see a little bit of a signal in the 50 or so cases we've done so far. The residents were the most skeptical and the most likely to rate a summary as not as good as the attendings, PAs. But that's no significant differences yet that we saw.
That's great.
They are the frontline providers, so I wonder if there's a little bit of kind of nuance that they're worried is not being in there. But I feel like from the attending physician level, like there are high level things that need to be in the note, and the rest is all filler for us. And so I wonder if there's a little bit of a mismatch leading to that kind of. But who knows?
And it's a little bit of a Goldilocks thing too. There's some people are saying there's way too much trivia in this summary. I don't need all this like. You could just say the labs were fine. You don't have to kind of give me like how high the glucose was above baseline or something. And then other people are like, there should have been more detail about this or that didn't make it in. So I hear and like it's an iterative process, and I think maybe people will end up customizing their summaries to match the way that they like to give handoff.
Yeah.
So I'm curious, how did you constrain GPT? Is this just an out of the box, or did you get few shot? Is it a RAG?
Yeah, we had a few shot model. We had some what we had deemed as really quality summaries, and we're not even calling this a handoff. It's really just a summary to facilitate handoff. And so it just happened to be what our team kind of thought made a high quality handoff, but obviously that's not going to work for everyone. And so we tried to follow this IPASS framework at least. But yeah, I could see how like there were times where GPT honed in on detail that was not related to the reason for admission. Sometimes though, as you're giving it notes that have been written about the encounter, maybe those notes are kind of out of date already, or like they were written very early in the visit and they're not as helpful anymore. And so that's what GPT had to glom onto. So sometimes it's just the substrate that it's working with.
Gotcha.
There's a risk too when you put things in front of like clinicians as they're actually going about their job. You run the risk that they're too busy to really give a meaningful reply. Although we did get some wonderful ad-lib kind of comments, but also I think folks are just kind of so grateful. They're like, oh yeah, this is wonderful. Thank you. I need this. And then you don't get critical feedback. Like there is something to be said for like bringing people into a room and giving them an opportunity to kind of thoughtfully evaluate some of these outputs. Because when you just show it to them as they're working, like they're just maybe not as critical as they could. But yeah, so the triage work, I'm curious, I'm interested about, and I'm thinking of a comment that I saw online. I think it was Graham Walker actually, the out of
I did see that
Kaiser.
comment.
Yeah. But
He's
yeah,
skeptical.
well, no, I think what he was saying is that, oh, it's wonderful that AI can, prognosticate at triage. We already have someone who can do that, and it's the board certified emergency physician. And yet, if we called bed management and said, there's a very high likelihood that this patient's going to get admitted, why don't you just reserve a bed for them now so that we're not boarding them for hours later? I don't think bed management is ready to bank on my prognostication, and so maybe the AI will sound more authoritative. Or maybe they're like, I recall Dan Buckland at Duke had an approach where it was like, yeah, each individual case there's some probability, but in aggregate of the last 10 patients, we can tell you that 4 of them are going to need beds. We're not exactly sure which 4,
Yeah.
but probably 4. Yeah.
I think, at least to me, the takeaway wasn't so much with the use case of like ED triage, right? It was, we were trying to say with kind of greater constraints on the model, can you safely apply these things in a clinical domain for a clinical task? And so I think what we showed was that you could, out of the box, it doesn't really work as well, or it actually worked, surprisingly okay, but certainly nothing you would ever implement clinically. But as you increase the constraints, whether it's few shot or a RAG with few shot, or giving it the actual ML probabilities, like all of these methods going forward are things that I think are going to be necessary to make sure that the LLMs aren't creative, aren't super loquacious, and kind of stick to the task. And so I think that was our takeaway, not so much we were saying like, haha, we figured out the triage prediction. So
I think, also, looking at some of the things you maybe touched on, Nick, some of the other applications for AI in emergency medicine. I think one of the things that we had talked about in one of our first episodes with Chris Alvin and Garrett Adams at Epic was discharge instructions and sort of tailoring those to the patient. And I think you touched on that a little bit. I think it's a kind of a real potential area for expansion. And I'm just wondering kind of what you've done with that specifically, or if you have any ideas.
Yeah, and we have an inpatient initiative underway about patient-friendly discharge narratives that explain the entire hospitalization and the ins and outs, and why this thing happened on day 3 and why that thing happened on day 5. Maybe the need was greater there because the patients are handed this kind of volume of text at discharge, and it's hard to parse. But I think, I'm thinking of all these occasions when patients show up in the emergency department and they're like, yeah, I was at this other institution, or I was here a few weeks ago and they did nothing, or I don't know what happened, or like, and you can look at the discharge instructions and they're very detailed, and they kind of have all the test results and radiology reports and then like some canned text about, cholecystitis or like with a little picture of a gallbladder. But it's clear that it's hard to put this together for the patient. And I'm really excited about the potential for generative AI to kind of weave together the patient's complaint and what the doctor ordered and what the lab results showed and why that led to the plan at discharge that was followed. And then very explicitly kind of saying like, yes, your doctor ruled out these feared conditions, so you don't have to worry about that, or at least you're below the threshold for further testing for those things. And now here's what you got to focus on, and here's the next steps. And part of that is follow-up, and part of that is this medication that doesn't seem to be doing anything, but it's critically important. So I think those kinds of summaries are going to be helpful. And then, gosh, the potential for just maybe pointing your phone at a QR code in the discharge paperwork and then like getting a bot or something that the patient can. So many times the patient ends up with questions after they're gone. And we have a follow-up center, and we have an opportunity to kind of talk with the patients one more time the next day or a few days later. But, as the patient is kind of thinking about it on the drive home or something, they could potentially interact with a bot someday and just kind of say like, well, all this sounds great, but you're not talking about this abnormal test result. What does that pertain to? Or just questions that they might have after they're gone. I think that's an exciting potential too.
Yeah, that's great.
we need that. You're right. We need a a digital provider after discharge that can answer all the kind of lingering questions.
And of course, with safety parameters, and like you can't just and maybe so when we do have that callback center reaching out to the patient later, they could view the transcript. You can see what the patient and the bot talked about, and gosh, if the patient does say something really concerning, if it can escalate sooner rather than later to someone on call who can reach out to the patient if they're describing something worrisome.
Right. I feel like this is one of those areas where medicine may be kind of lagging, because I tried to call FedEx about a package that just went missing. And the amount of runaround that they have, just so much automated messaging for you to interact with before you can get to a human, it's wild. And now, obviously, I don't think we should make it obstructionist like they're doing, but there's something there, right? There's an off ramp to handle a lot of the kind of lower issues without bringing a human in.
Thanks so much for listening to the first half of our conversation with Dr. Nick Jeans from NYU. Tune in next month for the second half of our conversation. Also, if you're interested in looking at some of the content and articles that we discussed related to this podcast, head on over to our website, stataipodcast, all one word, .com, stataipodcast.com. Also, if you're interested in being a guest or have any ideas for some interesting guests, we'd love to hear from you.
Please note that the views, opinions, and information expressed in this podcast are solely those of the individual speakers and do not necessarily represent those of their employers, our sponsors, or any affiliated organizations. The content provided is for informational and educational purposes and is not intended as medical advice. We encourage you to consult with qualified healthcare professionals for any medical concerns or treatment decisions. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. Listener discretion is advised.